everyone. Myself Dr. Avinash Rohila. I am from Swami Rama Himalayan University from Physiotherapy department. Today I would like to present a topic on management of spinal cord injury. As you know, management of spinal cord injury, as you know, our spinal cord is divided into like 4 parts like cervical, thoracic, lumbar and sacral. Spinal cord injuries can be defined as a traumatic or non-traumatic event that leads to neural damage that influences motor, sensory and respiratory function as well as bladder, bowel and sexual functions. Spinal cord injury most commonly results in paraplegia or tetraplegia. Paraplegia is the loss in motor and or sensory function in the lower limbs and trunk, while tetraplegia includes the upper limb to the motor or sensory loss of both the lower limbs and trunk. Now, important concept of physiotherapy in spinal cord injury. It's important that all physiotherapists understand the following concepts and their relevance to the management process. Vertebral injuries, acute phase, it affects the intensity of the therapy. Spinal shock, reflexes are temporarily absent for 3 days to 3 months. Autonomic dysreflexia, spinal cord injury about T6 leads to increased sympathetic activity. Orthostatic hypotension, blood pressure associated dizziness due to postural changes mobilizing from spine to sitting. DVTs and pulmonary embolus, known the signs and symptoms of this condition to ensure the safe therapy. Bladder and bowel dysfunction, pressure ulcers, prevention forms part of therapy sessions. Heterotrophic ossification like means calcification of soft tissue that can lead to contractures. Psychological and emotional distress, notice the sign and symptoms and refer to the appropriate team members. The process involves 5 steps. Step number 1, assessing impairments, activity limitations and participation restriction. Step number 2, setting goals with respect to activity limitation and participation restriction. Step number 3, identifying key impairments. Step number 4, identifying and administering treatments. Step number 5, measuring the outcomes. The management of individuals with spinal cord injury can be divided into 3 phases like acute, subacute and chronic. In this, subacute means like rehabilitation phase, chronic means long term rehabilitation phase. During the acute and subacute phases of treatment, rehabilitation strategies focus more on prevention of secondary complications, promoting neuro recovery, addressing underlying impairments and maximizing function. In chronic phase, compensatory or assistive approaches are often used to rehabilitate the patients. Now, let us come phase wise. Acute phase, the prevention of complication arising from spinal instability or neurological compromise involves all members of the multidisciplinary team. In this early phase post injury, physiotherapy management is predominantly involved in the prevention and the management of respiratory and circulatory complications as well as minimizing the impact of immobilization on the individual. For example, we can take like pressure ulcer and contracture development. Now, objective for acute phase of treatment are treatment objectives in the acute phase, which includes like to institute a prophylactic respiratory regime to manage respiratory conditions and any complications as a result of the spinal cord injury or associated condition. Example, decrease incidence of atelectasis, enhance the clearance of the secretions. To achieve an independent respiratory status where possible, to maintain the full range of movement of all the joint within the limitation determining by the stability of the fracture, to monitor and manage the neurological status, to manage and strengthen all inverted muscle group, to facilitate functional patterns of activity, to support and educate the patient, caregiver, family and staff. Now, let us come to discuss of respiratory function. Common secondary complications include hypoventilation, atelectasis, secretion retention and pneumonia. The respiratory function is affected due to disruption in the spinal cord relevant to the neurological level of the spinal cord injury. Level of innervations are C3 to C5 that is diaphragm, C3 to C8 that is scalene, C5 to T1 that is pectoralis, T1 to T11 intercostalis and T6 to T12 abdominals. Individual with C1 to C3 tetraplegia requires mechanical ventilation, while most individuals with C4 tetraplegia will be able to breathe independently. Although individuals with spinal cord injuries from C4 to T12 can breathe independently, they might still have reduced vital capacity and difficulty in raising intra-abdominal pressure for an effective cuff or other force expiratory techniques. Physiotherapy intervention should always include secretion clearance and increased ventilatory techniques. Secretion clearance technique include percussion, vibrations and shaking as well as postural drainage and suctioning. Treatment to improve ventilation includes abdominal binders, positioning, deep breathing exercises, incentive spirometry and inspiratory muscle training. Other medical equipment often used to improve ventilation are continuous positive airway pressure CPAP and bilevel positive pressure, that is BiPAP. Now come to range of movement. Reduced range of movement may lead to contractures due to immobility and poor positioning as well as increased tone and spasticity. Treatment technique should include passive stretches, positioning in the lengthened position and other common hypertonic treatment techniques such as compression, heat and sustained deep pressure. Now, the prevention of pressure ulcers. Areas prone to pressure ulcers include the occiput, scapulus, sacrum and the heels when lying in supine, while the greater trochanter and malleolae are more prone in sideline. In the acute phase, interventions include passive pressure care such as frequent rolling regimes and mobilizing as well as adequate skin moisturizing, nutrition and monitoring. Later in the subacute and long term phases, individuals will be taught how to perform frequent self lift techniques in order to relieve pressure. Now, to maintain and strengthening the inverted muscles, we can do progressive resistance training and functional strength training is clinically identified to achieve favorable results in maintaining and strengthening the inverted muscle group. Dosage of the strengthening includes 1 to 3 sets of 8 to 12 repetition with which rest 1 to 3 minutes between the sets, load of 60 to 70% of repeated maximum pressure 2 into 3 times per week in order to target endurance, reduce the load and increase the repetition. Now, let us come to subacute rehabilitation phase. Rehabilitation require consideration of the whole person, their physical, psychological, vocational and social background. The rehabilitation process is a goal directed and time limited process aimed at facilitating maximal independence and optimal reintegration back into the individual chosen community role and lifestyle. Physiotherapy is a key component during the rehabilitation process following spinal cord injury and includes a variety of interventions that addresses multiple domains in the international classification of functioning, disability and health, including body function and structure, activity limitation and participation, with many interventions directed at preventing rather than treating impairments, activity limitation and participant restriction. Quality of life include community participation, gainful employment, interpersonal relationship and leisure activities have become the overriding focus of management. Objectives. Treatment objectives of the rehabilitation phase includes to establish an interdisciplinary process that is patient focused, comprehensive and coordinated, to address physical motor functional activities with early intervention and management to prevent further complication, to improve an individual independence in activities of daily living such as bathing, eating, dressing, grooming and mobility, to achieve functional independence whether physical or verbal equipment in order to facilitate their independence, to achieve and maintain successful reintegration into the community. The range of therapy activities used by the physiotherapist during rehabilitation varies depending on the level and the type of injury. The three most individual therapy activities for individuals with high level tetraplegia were range of movement, stretching, strengthening and transfers. While for those with low tetraplegia, more time was spent on transfer than strengthening. Similarly, in individuals with paraplegia, the most common individual physiotherapy activities were transfer followed by a range of movement, stretching and strengthening. Individuals with different level of spinal cord injury performs different motor tasks differently, and it is important for physiotherapists to understand which functions are obtainable relevant to the spinal cord injury level. All motor tasks should be divided into subtasks in order to perform the activities optimally. In order to perform motor tasks successfully, individuals should have sufficient strength, balance, range of motion and knowledge or skill regarding the specific motor task. All this aspect can be achieved through frequent progressive training. Now let us come to bed mobility and transfer. C6 and lower spinal cord injury have the ability to attain 5 motor skills, that is rolling, mobilizing from supine to long sitting, unsupported sitting, lifting vertically, transfers. C6 tetraplegia may have some challenges, but these 5 motor skills are still possible with some modifications. With rolling, C6 tetraplegia should externally rotate shoulder and swing arms across the body instead of overhead. During an unsupported sitting, C6 tetraplegia should externally rotate shoulders and lock elbows in extension to maintain the balance. Vertical lifting for individuals with C6 tetraplegia can be possible by passively extending elbows, external rotating shoulders and depressing shoulders to weight bear with hands placed anteriorly to the pelvis. Now come to wheelchair mobility. Individual with C1 to C4 tetraplegia requires powered wheelchairs. These wheelchairs may be controlled by chin movements, sip and puff or head array. Individuals with C5 tetraplegia most commonly use wheelchairs controlled by hand movements. Most individuals with C6 to C8 tetraplegia are able to independently mobilize with a manual wheelchair, however might use hand controlled wheelchair as alternatives. Individuals with spinal cord injury lower than C8 will be able to independently mobilize with a manual wheelchair. Gait and standing. Gait training, strengthening and balance exercise were the most common physiotherapy activities in individuals with an AIS-D spinal cord injury. Overall strengthening was the most common group therapy activity across all level and types of spinal cord injury. Standing can be attained by using assistive devices such as tilt table, standing wheelchairs and or standing frames. Individuals with paraplegia might be able to stand in parallel bar using knee extension, splints or orthesis. Now let us come to long term phase. Individual with spinal cord injury, depending on the level and the type of lesion, may have many complex needs and face wide ranging. Long term restriction in their ability to live independently, drive or use public transport, return to work and education. To ensure successful long term management, coordinated community rehabilitation services and long term support is required to meet the long term and ongoing needs of individuals with spinal cord injury. Best practice in long term management includes active management with case managers with appropriate training, clinical expertise and knowledge of service to coordinate care post initial rehabilitation and ensure ongoing personalized case management for patient with complex or ongoing needs. Objectives. Treatment objectives of the long term phase includes to achieve a high level mobility goals required for community participation, to monitor the recovery of function, to reinforce family and caregiver training. That is it. Thank you.